Hi everyone, thanks for listening to my presentations. I'm back again, but this time around is going to be about treatment of the sleep apnea. Now I'm talking about positive airway pressure. Okay, if you haven't listened to my presentation on obstructive sleep apnea and central sleep apnea, please kindly do. With that, let's go. Okay, when you say PAP, don't confuse that with pap smear. No. I know the young ladies are excited because they've seen pap. I'm not talking about pap smear right now. I can do that some other day. Okay, but for now, it's positive airway pressure. Positive airway pressure is the main therapy for obstructive sleep apnea in adults. Positive airway pressure maintains continuous positive pharyngeal and transmural pressure. I'll go into examples of them in a bit. Intraluminal pressure will exceed the surrounding pressure. That will stabilize the upper airway by increasing end-expiratory lung volume. And the trouble we have been battling with when it comes to upper airway collapse will be nullified. Isn't that a great help? Yes, it is. Positive airway pressure will decrease daytime sleepiness, will improve health complications generally, will reduce apnea-hypopnea index per hour, will probably improve symptoms of congestive cardiac failure, atrial fibrillation, or gastroesophageal reflux disease. It is better than mandibular advancement devices, though some may prefer the mandibular advancement devices. What are the types of positive airway pressure? It could be delivered via continuous positive airway pressure, bilevel positive airway pressure, and auto-titrating positive airway pressure. One example of positive airway pressure is continuous positive airway pressure. That delivers a constant positive airway pressure throughout the respiratory cycle. It uses a pressure relief setting that lowers the positive airway pressure at the onset of exhalation. The bilevel positive airway pressure will have two parts: the inspiratory positive airway pressure and the expiratory positive airway pressure. So they're going to set the device in such a way that there'll be difference between Apap and Apap when you're dealing with Bpap. The difference between Apap and Apap is the pressure support, or called the tidal volume. That is exactly what the patient will be using. For example, the tidal volume of 15 centimeters of water will be set in such a way that the Apap will be 20 centimeters of water and Apap will be 5 centimeters of water. So the difference between the Apap and Apap is that 15, and that is what goes in the patient. We have to note that Bpap is urinic, that is bilevel positive airway pressure, but many people will be familiar with Bpap. Bpap is just a brand name, and the company is so fortunate that many people is familiar with that, Bpap. Apap, or auto-titrating positive airway pressure, is called the name because it is auto-titrating. It increases or decreases the level of positive airway pressure in response to either changes in airflow or changes in circuit pressure or vibratory snore. a clue that there is upper airway resistance. Isn't that great? It's auto-titrating, right? So it's going to increase or decrease the level of positive airway pressure on its own depending on the changes in airflow or the changes in circuit pressure or when there is vibratory snore. Immediately, that will give a clue that there is upper airway resistance and it's just going to titrate and adjust on its own. ASV is adaptive servo ventilation. This is dealing with varying amount of inspiratory pressure. It is useful in central apnea. And we're going to use it in continuous positive airway pressure induced central apnea or in narcotic induced central apnea. It's useful in stroke. It's useful in renal failure. There will be increased mortality with adaptive servo ventilation if we have left ventricular ejection fraction that is less than or equal to 45%, particularly in those with congestive or congestive cardiac failure or congestive heart failure and with Cheyne-Stokes breathing pattern. Cheyne-Stokes breathing pattern is tagged as central sleep apnea Apap ventilation. So it's a big issue. We use it in all these situations. And when there's left ventricular ejection fraction, let's just do what is appropriate. Let's refer appropriately for implantable cardiac defibrillator because they are prone to defibrillation. And when they have ventricular fibrillation, that might lead to death quickly. What are the indications for positive airway pressure? Some give continuous positive airway pressure to all patients diagnosed with obstructive sleep apnea. I have no objection. Okay. Others will measure and give it only to those with respiratory disturbance index greater than or equal to 15 per hour or respiratory disturbance index between 5 and 14 per hour with signs and symptoms and complications of obstructive sleep apnea. In other words, once the diagnosis of obstructive apnea is made, they just prescribe Cpap. No objection to that. Other doctors will go into more stuff, polysomnography report out. Are there symptoms? Are there signs? Are there complications? And of course, the second category, that is the people that will do all this in looking for signs and symptoms and complications, whether be those that will be treating the patient that are covered by the government, but where patients will just walk to the clinic, spend their money, many people will just prescribe Cpap. Many are comfortable giving Cpap when AHI is greater than 5 events per hour of sleep. That is Apnea-Hypopnea index, with one or more clinical or physiological complications secondary to obstructive sleep apnea. Just to say that it's not all clinicians that will prescribe Cpap just like that. Some will take some other parameters. And I will prefer, if it's not giving complications, it's not giving signs and symptoms, let the individual embark on some behavioral changes like stop smoking, stop alcohol, lose weight. Then let's see how that will improve the situation before we prescribe Cpap. But if it is disturbing the life of the affected patient and couldn't sleep, because I know the complications of lack of good sleep, or daytime sleepiness is disturbing the productivity of the person, and the person is even prone to road traffic accident, why not give the Cpap? So it's controversial, sort of. So, but in all, the safety, productivity, well-being of the patient will be more important than all these parameters. Still on indications for prescription of PAP is also given to apnea-hypopnea index greater than or equal to 15 events per hour of sleep in the absence of symptoms. This is very good. So, no symptoms, you are not picking complications, but the apnea-hypopnea index is 15 per hour during sleep, just prescribe. All those who perform critical work should have Cpap. I agree completely, absolutely. Pilots, air controllers, bus drivers, truck drivers, doctors, nurses, police officers, sailors. I've been mentioning all my friends. Somebody is saying I'm not mentioning teachers and pastors. Everybody, anyone that is performing critical work, because mistake, when you make mistake, could cause lives, and even the life of the affected person and the life of many that will be under their watch. So we are getting back to the first level. Just prescribe Cpap once you are sure of the diagnosis and refer to sleep experts. PAP follow-up. Follow-up is very important because adherence is a big issue. For many patients who opted for any of the PAP devices, we have to follow up. It could be monitored remotely, and the pressure could be adjusted remotely as well. And some who will not be honest as per whether it's being used or not, particularly in places where the elders have been abused. Now, maybe those elders are supposed to be held with, applying the Cpap before sleeping, and well, with all due respect, whoever is looking after the person is not having to do that. Maybe they don't know that remotely it could be monitored, and they will know that it was not applied. The side effects could be corrected immediately. Can be placed on long-term regimen once PAP therapy has been optimized and symptoms resolved. Anyone using positive airway pressure should visit the clinician once you have any issue. If you have any concern, don't keep it yourself, because that is saving your life. Otherwise, visitation annually is reasonable. In medicine, you will not be doing your patient good if you only re-emphasize only what you want to do. We should tell our patient the alternatives as well. They are free to make their choices, as we'll be there to guide. The alternatives here are oral appliances like Mandibular Advancement Devices and tongue retaining devices. So they can try that out. Actually, some prefer that to continuous positive airway pressure or Bpap. Hypoglossal nerve stimulation surgery like maxillofacial surgery, otolaryngologists or ENT surgeons, depending on the nomenclature you call them, in your own parts of the world. Okay, I've come to the end of positive airway pressure as far as assisting people with sleep apnea is concerned. And if you have listened to me very well from beginning to now, I have mentioned some other conditions where we will use it. So thanks for listening to my presentation. Kindly subscribe to my channel My next presentation will be on polysomnography. What is that all about? When you click next time on polysomnography on my channel, you will have all the facts. Thank you.